Sir, good morning, sir.
Good morning, sir. So, my patient, a 52-year-old male, Singapore Jaipur, service professional by occupation, admitted with chief complaints of upper abdominal pain and fullness since 2 years. Dyspepsia on and off since 8 months. History of present illness. Patient was apparently alright 2 years back when he died, being in abdomen. It was delicate, occasional to begin with. It was 3 to 4 times a month initially, mild to moderate in intensity, radiated to back, was relieved on medication. He took some over-the-counter painkillers. It was sometimes aggravated with heavy meals and it was not associated with nausea or vomiting. Patient consulted an Ayurvedic practitioner and was advised dietary changes in terms of low-fat diet and some medications. And he showed some symptomatic improvement. But since last 8 months, the pain has returned and it has increased in frequency. It is from being weekly to now almost daily. It is similar in intensity and again is relieved by medications. But now it is associated with dyspeptic symptoms in terms of postprandial fullness, upper abdominal bloating or dizziness, relieved after passing flatus, and associated with a decreased. The patient also has a history of frequent constipation since last 2 years. History of occasional foul smelling oily stools which are difficult to flush after fatty meal. There is history of unintentional weight loss of around 11 kgs in last 4 months. Patient was started on
Ayush,
medication.
can you go back previous slide?
Yes,
I'm not sure whether this is a standard terminology, gasiness.
sir, that's why I've written upper abdominal bloating. That was the word that the patient used, so I've kept it as a.
But I think
Uh,
you don't need to actually just write whatever patient says because it's your interpretation, and then you mention the correct medical term. So gasiness, I think the patient will keep on describing so many symptoms in so many ways, depending their own interpretation, right, in their own language.
okay,
So
sir.
I think it is better to avoid such terms rather than use standard terms. So it is once you
Okay.
have said that it is bloating, it itself says that it is because of underlying gas or something like that. So bloating is a standard terminology. Avoid such things, right? Okay, go ahead.
Okay, sir. The patient also gives a history of unintentional weight loss of around 11 kgs in last 4 months. Patient was started on medications to be taken with meals 3 times a day since 1.5 months, and weight has now stabilized. And now he reports some regain of weight. There is no history of any palpable lump in abdomen. There is no history of jaundice, melena, or clay colored stools. There is no history of nausea or vomiting, and there is no history of hematemesis. There is no history of fever. There is no history of generalized weakness or easy fatigability. There is in our verdict when there is no history of recent abdominal trauma. When the past history, patient was apparently alright till 18 years of age. In May 1990, he had severe abdominal pain and distension. He was admitted in a hospital in Kota, developed noise block, respiration around umbilicus during his admission. He underwent an experimental laparoscopy and was diagnosed to have acute pancreatitis, for which the patient says a lavage and some cleaning was done. Probably lavage was done. After discharge, patient had no fresh symptoms and he maintained his appearance. He underwent a follow-up USG after 6 months, and he says that they reported some cystic lesion in the pancreas. So he again consulted a hospital in Delhi. He underwent a ERCP followed by a laparotomy, and the cyst was drained as per the patient, and a part of his large bowel was also removed. The recovery was uneventful. In 1993, patient had an incisional hernia repair, which was also uneventful. In 1997, patient had repeated fungal infections for which workup was done. He was diagnosed to have diabetes mellitus, was started on oral hypoglycemics, but was shifted to insulin since 2002. His sugar controls and insulin doses remained unchanged for the next 20 years. But since last 2 years, his insulin requirement has increased. He undertook some dietary modification and continues to be on the insulin supplementation. There is also a history of recently diagnosed hypertension, but he is on irregular medication since last 4 months. Personal history. Patient takes a vegetarian diet, reports disturbed sleep due to abdominal pain since last 2 months. There are no known allergies or addictions, and patient is a teetotal. Family history is not significant. So shall I summarize?
Yes, please summarize.
So a 50-year-old gentleman presented with history of recurrent pain in abdomen, radiating to back and dyspepsia for 2 years, with endocrine and exocrine insufficiency on insulin and likely PERT supplementation, with recent deterioration in the pain and diabetic control, and reports a significant weight loss, and with a history of surgical drainage in past.
So why did you say it is with exuberant insufficiency?
So the patient gives typical symptoms of on and off constipation. There is also history of abdominal bloating, post-vagal fullness. There is history of sometimes when he eats outside. There is a history of foul-smelling, oily stools, and he has been started on a medication that he has to take in between the meals 3 times a day since last 1.5 months. So it is likely for supplementation given for exocrine infections.
I think this statement will go more in the diagnosis, differential diagnosis or tentative diagnosis part rather than with the summary, isn't it? Because once you label it that with endocrine and exocrine insufficiency, right? So it means
Okay.
it has become now kind of this thing that we're thinking in terms of certain diagnosis rather than summarizing the history. What my point?
Okay, sir. Yes.
And history of surgical drainage. So you have not mentioned this thing in the past because he has a very significant past history with multiple surgeries, at least three, and with one episode of acute pancreatitis, right?
Yes.
So he has a very significant past history. So with the summary, I think you have just mentioned the previous 2 years history. So that part has to be included in here also because that is very significant and that is that might be responsible for the current symptoms or current problems,
Right, sir.
or it may
Okay,
be
sir.
the same problem which has progressed in the last many years.
Yes, sir.
So it may be the same pathology which has presented in different ways at different point of time
Yes, right.
in the last many years. So it is, I think, don't confine summary to the present complaint. If there is a significant past history, then you have to mention here also. So I think many things are clear based on history. What is the literacy status of patient? What is
Yes.
occupation?
Sir, he is a service professional. He works in a government office and he is currently working.
Because he has categorically mentioned many things like cystic lesion, surgery, dissection of some
Yes.
part of the large bowel. Right. So
So the patient,
is he reliable in terms of whatever he is
so
telling?
the history was very reliable and he used many medical terms as well. So, and he has been on a regular follow-up since last 34 years. So he is aware of his diseases.
Right. So now, based on this overall case scenario, the current symptoms and the past history, what do you think is the problem he is having at present?
So considering the past history and relatively similar symptoms now, and the patient has had an episode of pancreatitis long back. And given his age, my first diagnosis would be of chronic pancreatitis with possibly a malignant transformation because patient also presents with a significant weight loss
What is significant
and
because
sorry, sir.
what is significant? When do you say it is a significant weight loss?
If it is more than 5% of weight loss in last 1 month, 1.5% in 3 months, and 3 months, and more than 10% weight loss in 6 months.
Right. So what is the category in this patient? It is five,
Sir,
7.5, or it is 10%.
so 7.5 because he has not given up. He has given that he had a weight loss of around 11 kgs in last 4 months, and his current weight was around 62 kg.
So it is better to mention in this terminology during the presentation rather than giving the absolute number because this 11 kg. So interpretation
Yes, sir.
would be different for a 100 kg patient from a patient who is having a weight of 50 kg or 40 kg. It would be
Yes,
more
sir.
significant in a patient with a 40 kg weight compared to an obese patient or morbidly obese patient. What my point? So you can mention the absolute weight loss, but you have to mention the percentage also, so that you can convey the right message, whether it is a significant or
Uh,
not significant. What my point?
oh, okay, sir.
Okay, so you are thinking of transformation into a pancreatic malignancy
Yes.
on the background of
Long-standing chronic pancreatitis.
long-standing. Sorry, I couldn't hear.
Chronic pancreatitis. Chronic
Long-standing
pancreatitis.
chronic pancreatitis. What is the common presentation of superimposed malignancy in chronic pancreatitis?
Uh, 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 common presentation is any recent deterioration in the normal course of the disease, that is of a, or rather benign course of a disease. Like if there is usually they present either with a new onset diabetes or worsening of the diabetic control. It can be with gastric outlet symptoms or with jaundice, and weight loss can also
See,
be
what
present.
is more common would be the jaundice,
Jaundice.
right? So, what are the more common causes of weight loss in such scenario in the patient with chronic pancreatitis?
So my second diagnosis would have been an acute exacerbation of a chronic pancreatitis in chicken sequelae. Because since last 2 years, it could be possible that the patient again had an acute pancreatitis, and that led to the further exocrine insufficiency, which may present with weight loss as
So, I think I would to consider more this weight loss more because of this exocrine insufficiency rather than
well.
because of
Yes,
the malignancy. Right.
yes, because
So we will leave this
it gives a
discussion
history
at
that
this.
with supplement.
We will leave this discussion apart here. So we will just go ahead with your diagnosis, because what is your diagnosis at present? Differential diagnosis, any differential diagnosis, or there is a just one single provisional diagnosis? What do you think?
Yeah, we do have a difference. My first diagnosis still would be a chronic pancreatitis, long-standing chronic pancreatitis with possibly malignant
What do you mean
transformation.
by the long-standing chronic pancreatitis? Is it a short-standing chronic pancreatitis? Is there any entity? See, once
No,
you say it is a chronic pancreatitis, it means it is a chronic disease, right?
right, yeah, okay, so
It is already a chronic. Only thing is that you have diagnosed at one particular point of time. So once you are labeled it as a chronic, it means it has been there for.
but since the and it commonly presents with the jaundice, but in this patient, I would still consider a possibility in the body because the presenting symptoms are not jaundice or a gastric ulcer.
May I
Why?
interrupt, sir? Just
Sure,
one
sir.
question.
Please.
Yeah. You gave history suggestive of acute pancreatitis, which was confirmed at laparotomy, and they did some debridement and lavage.
Yes, sir.
So, if that was an episode of necrotizing pancreatitis, could this be something else, entity related to treatment of necrotizing pancreatitis? Like disconnected duct syndrome, could it be that?
Okay. Yes, it could.
Disconnected duct syndrome also will present with history like this. And they say that you are not supposed to say that an attack of chronic pancreatitis has started as an episode of acute pancreatitis. They are two distinct entities.
Okay.
Either you call it an acute exacerbation
Okay, sir.
or you call it chronic pancreatitis. You can't say acute pancreatitis has got converted to chronic pancreatitis over many years. That is not an acceptable terminology according to the modified Atlanta.
Yes.
So, what do you think it is?
So it is a possibly a chronic pancreatitis. It is with history. It is a chronic pancreatitis.
Can
I
you
think
rule out
what
disconnected duct syndrome?
I think what
It
sir is
cannot
trying
be
to
conclusively.
ask you, what sir is
Yes, sir.
trying to ask you, whether it is a chronic pancreatitis per se since its beginning, or it was something else in the during the initial presentation, and now it is something else.
Uh, yes, my second diagnosis is it was acute exacerbation in the last 2 years, and which might then lead to a stricture formation or a disconnected duct syndrome. And then this can present with the symptoms that the patient has.
So it is
Coming
possible. So
back
you
to the
should have it in your
disconnected duct.
differential.
Coming back to the
Yes.
what sir has asked, whether disconnected duct syndrome can lead to current chronic pancreatitis.
Because there's a clear-cut history of cyst formation, surgery for that, decompression of the cyst, resection of the colon. Why was the colon resected? Was it injured? Did thrombosis occur? And there was colonic gangrene. What was the mechanism by which the colon had to be removed? That should be elaborated more if you can.
The patient did give a vague history that the cyst could not be taken out without compromising the colon, so they took out the colon. It was many years ago.
Yeah, so a lesser sac cyst was removed. So when there is an acute pancreatitis episode, there is history of a cyst formation which was treated. You have to
Yes, sir.
consider disconnected duct syndrome as a possibility.
Okay, sir.
Because the duct has disrupted and only then the cyst can form, isn't it?
Yes, sir.
And if he's now getting pain, is the pain more restricted to the left side of the abdomen and the radiation to the left side? Is it how severe has it been right from the beginning is important.
The pain, he says, is mostly in the entire upper abdomen. There is no particular site of radiation. However, he says it radiates to back. And the pain has been mild to moderate. He is able to sustain the pain with just oral medications. But the frequency has increased.
Okay. What is the difference in cysts in chronic pancreatitis and cysts in acute pancreatitis?
For acute pancreatitis, the cysts usually tend to resolve in most of the cases. And with chronic pancreatitis, these cysts, it has been given that less than 2% of the cysts resolve on their own. They tend to persist for long.
No, what do you call? Is it a pseudocyst you're talking about? Because definitions are very, very different. You understand?
Yes, sir.
If it is if it is after 6 weeks of acute pancreatitis, you'll call
Then
it
we
a
do call it.
pseudocyst.
Then we call it a pseudocyst. Here it would
Yeah.
be
So
just.
does this fulfill that definition, or was
Yes.
it an acute fluid collection?
So it does fulfill the definition of a pseudocyst.
So it's a pseudocyst. So is it an acute and chronic episode with rupture of the duct leading to formation of a pseudocyst, which seems likely because
Yes, sir.
most chronic pancreatitis pseudocysts are restricted to the body and head, body and tail of the pancreas, and they are within the capsule. They're usually
Yes, sir.
smaller, and only when the duct ruptures because of an acute episode, they can get a pseudocyst. And these pseudocysts don't resolve easily because there's an abnormal duct.
Yes.
Yeah. It's important for you to stay within Atlanta
Yes.
modified.
So you said your diagnosis is chronic pancreatitis.
Yes, sir.
What is the cause of chronic pancreatitis? What do you think is the cause in this patient?
It was the patient had pancreatitis. It was the very first episode in his very teenage days. So when he was not drinking, he had no addictions back then. He was not smoking. He was not drinking. There was no history suggestive of a long-term biliary colic or repeated attacks of biliary colics before or after for the surgery. He was of a decent weight even before the surgery, so I could also rule out a history of a possibly tropical pancreatitis. I'm not sure, sir, about the cause of the pancreatitis because one was not
Right. What was the age when he had first episode of this thing, acute
18 years.
pancreatitis?
18 years.
So what do you think would be the cause, considering his age when he had first episode of pancreatitis? What is the natural history of acute pancreatitis? Because he was operated for some complication arising out of acute pancreatitis, right?
Likely
So,
chronic complications.
what is the natural history of acute pancreatitis? How many patients develop chronic pancreatitis once they recover from acute pancreatitis? First, what do you think? What was the kind of severity of acute pancreatitis? The first episode. What is mild, moderate, or severe?
So it was severe because patient had it was severe because the pain persisted, and I don't have his organ status as to organ failure status back at that time. He underwent a surgery for a hemorrhagic complication, so I would consider it to be a severe.
You think it might be a severe pancreatitis. So, what is the natural history of severe acute pancreatitis? How many of these patients develop chronic pancreatitis in next many years, next 1 or 2 decades? Any idea?
Sorry, sir, I'm not aware of the exact percentage.
So I think it is around 20-25% of these patients, they actually develop chronic pancreatitis. They follow them for a long period of time. And one of the reasons Saresh mentioned that disconnected duct. So for the post necrotizing pancreatitis, actually you can develop the ductal stricture, right? And that can lead to either the recurrent pancreatitis or ultimately the chronic changes. But the thing is that what was the cause of first episode of acute pancreatitis? That you have to think of. So considering his age, it might be some genetic cause might be there, right?
Yes.
So that we cannot totally rule it out. The genetic cause of acute pancreatitis, right?
Yes.
So go ahead with the next slide.
You didn't mention whether he was a smoker or there was intake of alcohol or not.
Yes, sir. Sorry, I did mention. So he never smoked when he is a teetotaler.
Does
Just
it
run
drink?
through the previous slides. I think just run through the previous slides because the past history is important.
Yeah, okay, he's teetotaler. Yeah, thank you. So, what possibilities are there if he is a teetotaler for him to develop acute onset pancreatitis at 18 years? How likely is it hereditary pancreatitis?
So hereditary pancreatitis, it can be there, genetic causes can be there, but the patient doesn't give any significant history in the family. So some genetic transformation could be there. He has not been
He could
investigated
be the
for.
index patient. He could be the index patient. So,
Uh,
what are the anomalies that you would screen for? Would you get the tests done if they are available? What would you screen for? What genetic tests would you do?
so SPINK1 gene, PRSS1, PRSS2, uh, cystic fibrosis, CFTR genes, and
Yeah.
these are the commonly most
Going by
common.
its history, how likely do you think it is cystic fibrosis
Less
gene
likely,
abnormality?
less likely because it doesn't present with other symptoms of cystic fibrosis disease. And but again, it can not all the patients with the CFTR gene present with the non-pancreatic symptoms as well.
Yeah, that's true. But they present with cystic fibrosis. So, cystic
Yes, sir.
fibrosis, what are the manifestations in childhood and what are the manifestations in adult?
So usually the patients present with dry sinuses and sinusitis attacks. They present with respiratory complications. Uh, there is a typical history of excessive saltiness after smoking.
What about lung symptoms? What about meconium ileus? What is meconium ileus?
Yes, meconium minus because of the less mucoid secretions. Ileus, the meconium, the patients present with a tight, with rather tight or a high meconium, and they tend to obstruct an infancy itself. So these patients present with obstruction in
Okay. Uh, what about PSRSS? That is hereditary pancreatitis per se. Which decade does it commonly present?
Sir, there are two presentations. It is either first in the pulse was 82 per minute, the normal degree. Respiratory rate was 20 per minute. CO2 was 96% on room air, and blood pressure was 130 by 80 millimeters of mercury. There was no evidence of anemia, jaundice, cirrhosis, then edema, phlegmy, and his JVP was not reached. There was no palpable lymphadenopathy, and I specifically looked for a left side on abdominal examination, on inspection, surgical scar marks were open. There was a one right median scar and a bilateral postal incision. Abdomen was flat. Umbilicus is centrally placed. All quadrants were moving well with respiration. There were no dilated veins or visible peristalsis. Hernial orifices appeared normal with no visible curve symptoms. External genitalia appeared normal. And the spine was normal. On palpation, abdomen was soft, non-tender. There was no gutting rigidity. There was no organomegaly. There was no palpable or beneficial. Liver span was 11 centimeters. And on rectal examination, minimal yellowish stool staining was present, but there was no blood or malaria. Rest of the systemic examination was grossly minimal.
I think it is. Don't mention WNF because what is WNF? Within normal limits. So, what is the limits of respiratory system or cardiovascular system or CNS system? It is better to say it is anything, right? So, just summarize your positive finding on examination. Is there anything which is contributory, which can substantiate your diagnosis, or which can add any other diagnosis?
There was no positive finding in the abdominal examination, in the general and abdominal examination. However, I could rule out any massive lesion, massive lump or cystic lesion, a large lump or a cystic lesion in the abdomen. Uh, and I could also rule out. And it is very vague, but I could, there was no there were no significant lymphadenopathy or lymph nodes in this region. It was mostly normal examination.
So, the examination doesn't add to any your diagnosis. Right, it remains the same chronic
Yes.
pancreatitis. So, what is your final
Yeah.
diagnosis?
So my final diagnosis is chronic pancreatitis with the possible malignant transformation during the age of the recent details. I would like to screen the patient accordingly.
So still you are thinking it is some malignant process is developed. There is some malignancy superimposing chronic pancreatitis. Right.
So it would be the most high risk thing, and I would like to further evaluate the patient on these lines, but I have to consider a sort of acute exacerbation.
Acute?
Exacerbation 2 years in a patient of chronic pancreatitis.
Can you have acute exacerbation for 2 years?
So 2 years back, there was some acute exacerbation in the patient.
See, that might be there. That might be there. What we are talking about the diagnosis at present.
Yes.
See, patient might be having cholangitis 3 months back, 6 months back. But what we are talking about the diagnosis at present. He might have acute exacerbation 2 years back. But at present, the patient might have recovered.
थोड़ा हवा खुला कि नहीं गैस पास हुआ कि नहीं
Right.
Yes, sir.
रुकिए हाँ
Some disturbance was there. Right. So that was there in the past history. But what we were talking about the diagnosis at present. So acute exacerbation for 2 years, I think that is, I will not take it as a diagnosis at present.
Okay. So, sir, it would be prudent to just put it as a chronic pancreatitis as a course of chronic pancreatitis.
It might be a chronic pancreatitis considering the overall history, right? Overall progression
Okay,
of the
sir.
disease. But to say that it is superimposed malignancy, again, I would not consider malignancy, right? At this stage, it might be because of the underlying exocrine insufficiency.
Yes.
Right. Suppose he had jaundice, recent onset jaundice. Then I would have a strong suspicion of malignancy because jaundice is not explained by chronic pancreatitis per se. Right. So it has some complications. Right. So there is a possibility. Second, what about the anorexia? What is his appetite?
Sir, his appetite has decreased, but yes, his appetite is also decreased.
It has decreased significantly.
Yes, sir. He gives a history of decrease since last 8 months.
Last 8 months.
Yes.
Okay. Can it be any complication of acute pancreatitis itself rather than chronic pancreatitis? Is it a possibility?
Yes, sir, it is a possibility that the patient might have a complication of an acute pancreatitis in the form of either, as sir discussed, a disconnected duct syndrome or a small cystic or a small cirrhosis that has formed. Also,
so how will you
Is there
proceed?
any feature to suggest gastric outlet obstruction?
No, sir, there are no features.
You said postprandial fullness is there, dyspepsia is there.
Yes, sir.
So if
But it is
postprandial
not.
fullness is there, can you really rule out duodenal obstruction, which is a complication of chronic pancreatitis and also malignancy?
Possibility is
So-
there, but he never gave a history of either a nausea or a vomiting in the course of this.
No, in the early stages of obstruction, they may not give that all the components of the history, but when there is fullness, the fullness is because of either an extrinsic compression by a pseudocyst or a gastric outlet obstruction. Gastric outlet obstruction can occur through three mechanisms: pancreatic malignancy in the head, or pseudocyst in the head, or you can get obstruction of the third part of the duodenum by a growth in the uncinate process. And the growth in the head can obstruct either the first part of the duodenum or the second part of the duodenum, second part of the duodenum being more common. So you should have it in your differential diagnosis. You do want to rule that out. And also you should rule out any evidence of functional gastric disturbances, such as gastroparesis. It could be malignant gastroparesis because of involvement of the celiac plexus. It could be that. So you have to keep it in mind that this history is significant. You can't rule out that history.
Okay, go ahead. How will you approach this patient?
So first, I'd like to get the USD done for this patient. We just screen what screen any structural anomalies present in this.
So you don't want to review his records. You think the history is totally reliable? He is a totally reliable patient. Whatever he has said can be relied
Sorry,
upon. Yeah.
I would like to review the records as well. Yes.
Yeah, I think at this stage when he had a very significant past history, medical as well as surgical, it becomes very important that you must review all the records, right? Because if you
Yes.
don't review the records, then again it will be a problem. You might miss some other diagnosis.
Right.
What was the reason? Do you expect a portion of the colon to be resected for benign condition
Uh,
of the pancreas? Because he has categorically mentioned some part of the large bowel was resected during the
yes, sir.
second surgery after some ERCP was done, and then so isn't it important to review that report why the colon was resected?
Yes.
Is it a common situation or it is something kind of rare thing?
It is a rare thing, and it could present a more grievous condition with microdosing
So
pancreatitis.
do you want to know whether it was an emergency surgery or it was an elective surgery?
So I did ask for it, and it was an elective surgery. He
It
had
was
no
an elective
symptoms.
surgery, right?
Yes.
So what would be the indication for resection of a portion of the colon during elective pancreatic surgery for pancreatitis? It might be acute pancreatitis, it might be chronic pancreatitis. At this stage, we don't know what could be the cause.
So one thing it could be that during the surgery they found any strictures, colonic structure of the
Was
person.
patient was is there any symptom at this stage?
Those was no.
As sir has asked, could it be iatrogenic injury
Yes, yes, it can be vital in injuries.
or whether
Right.
the bowel got ischemic during the dissection or at
Could
ischemia? Is there any possibility because patient has already underwent surgery before that? There
has
might be some additions, either because of surgery,
yes,
because of inflammation. There could be many reasons, right?
yes,
So to review all those records is very important to understand what is
correct.
going on at present, and again to plan the further management, right? Because patient has underwent surgery twice, ERCP once, so he had underwent
Yeah.
some kind of interventions multiple times. He had a very
Yes,
complicated problem earlier also. So to plan a
yes, sir.
treatment, to make a treatment plan at this stage, reviewing those reports is very important.
Yes.
So do you have any report with you?
So I don't have the old records with that old records. But we do have investigations and reports in the last few months.
Okay, so what will you do? So this patient has lost all the records. You don't have any access to all previous records, right? So what will you do now?
Uh, so I'd I'd like my first screening would be a USG to begin with.
Why ultrasound? I will say get CT scan directly. You have a suspicion
Yes,
of
yes.
malignancy. You have a suspicion of chronic pancreatitis with superimposed malignancy. You do. See, I'm just giving you a suggestion. Get CT scan instead of ultrasound. So, what is the anything against this approach, or still you want to get the ultrasound first?
Uh,
Why you have changed your plan?
so it is a
See,
more specific.
I might be wrong. See, I might be wrong. I'm just giving you a suggestion or option.
No, no, I do agree, sir. The CT scan would be a single and a more beneficial investigation. Even after a USG screening, I would have gone for a CT scan next. So I would consider that directly going for a CT scan.
But what if on ultrasound we have multiple liver SOLs, multiple large retrocuticular lymph nodes with mild
Yeah.
ascites and pelvis? Then
And what about portal hypertension, which is an important thing for you when you're going to operate? Integrity of the portal tree, whether it is inward, whether there is splenomegaly, whether there is portal hypertension. Don't you want to know that from your ultrasound, a Doppler ultrasound? And Doppler's ultrasound is also indicated for a mass-forming chronic pancreatitis because it's been shown to help in differentiation slightly, but more with endoscopic ultrasound rather than transabdominal. But it has been shown to make a difference. And also, it gives you a plan of doing the CT. You can modify the CT protocol based on your ultrasound findings.
Okay, so what do you have with you? Ultrasound or CT scan?
Yes. So
Okay,
I'm
what
going to
else you will
investigate.
do? What else? What else? We will discuss the imaging, but what else you will?
So I would also like to get a tumor marker done for this patient, particularly C99. The- and basic blood investigations like an NFP, serum creatinine, electrolytes, and a CBC, and a PTINR to
So
look for the liver
basically,
function.
you are seeing this patient, so you will advise for some basic investigation, some special investigation, and imaging, and you will start
Yes.
with the ultrasound, right? So,
Yes.
because this tumor marker is not the basic investigation, so you will get the basic investigation to assess for his nutritional status, his status in view of previous diabetes, exocrine insufficiency, right?
Yes.
And special investigation because you are suspecting malignancy.
Yes.
But what do you get tumor markers? Which one?
CA99.
So, is it increase in chronic pancreatitis also? How will you differentiate between malignancy and chronic pancreatitis?
So CA99 is said to not be a very reliable marker in a background of chronic pancreatitis. But again, very high levels might give some idea. At least baseline CA99 level, I would still like to.
Okay, go ahead with the investigation. Do you have reports?
Yes. Sir, investigations is hemoglobin is 15.3. His CBC is CBC, sodium, serum electrolytes, creatinine are grossly within normal range. INR is 1.32. His total bilirubin is 0.9, direct is 0.4, and indirect is 0.5. There is no transaminases, and his ELP levels are 50. So,
What is albumin?
patient,
What is albumin?
sir, in this particular, I did not have albumin. You have to get patient.
Oh, will you get it or not?
Yes, sir. Albumin is important because the patient presents with a weight loss, and I would like to see his past nutritional status.
So, considering that hemoglobin is normal, right? Other parameters are normal. INR is normal, LFT is normal. What do you expect? And clinically, there was no edema. What do you expect? This
I expect it to be normal. Normal.
right. So, broadly, these all investigations are normal. Anything else you would like to get before we go ahead with the tumor marker?
So
Anything else that is important? What is
HbA1c, HbA1c serum calcium would have been helpful.
Then, do you want to confirm that he actually has exocrine insufficiency because that was suspected based on his symptoms?
Yes.
Was at any time it was confirmed objectively? What will you get?
No, sir. So fecal elastase test.
You want to get
fecal, so even the history that with bird supplementation, his weight has stabilized and he has some improvement in the symptoms. I would likely consider a clinical diagnosis of exocrine insufficiency.
At some point of time during the management, you have to confirm it objectively. Because there are many reasons for this exocrine insufficiency, or I would say fat malabsorption. Because he has undergone surgery previously, and there may be many other reasons, not necessarily because of chronic pancreatitis. Okay, go ahead.
So also triglyceride level would also be in this patient because we don't know the primary cause of now.
Right, so CBC, LFT, electrolytes, albumin, they are normal. So next, what will you get?
So this patient was under guidance of some diabetic professional, was undergoing the CA99 levels every 15 days last 6 months.
So actually, this is a very interesting chart.
Yes. So since February, has significantly increased from 1,800 to almost 5,000 in last 4 months. And his serum amylase and lipase was across during this.
So what do you think? Why it was done thrice in 1 month? Someone else
So
has advice. Okay. So currently at present is CA 19.9 is more than 5,000.
yes,
Okay. So now what will you do?
again with although CA1990 is not reliable, these high levels would suspect a malignancy in this patient. And as I said, we would proceed with the first USG to rule out any metastatic disease.
But
But
you have
definitely,
changed. See, you have changed your management
yes,
twice again. You started with the ultrasound, you then switched over to CT scan, then again you are switching back to ultrasound. Got it? So now you are
yes,
getting
sir.
ultrasound based on this very high CA 19.9.
Yes, it is possible that because of the very high CA99, it can turn out to be a mistake. And USG would USG might show some drastic regions.
So USG has shown that there are multiple as well in the liver. Pancreas is atrophic. There is a
Yes,
bulky head, but there is no clear-cut mass. Or they are not able to comment on the pancreas because of overlying this. No ascites, multiple retroperitoneal lymph nodes. There is no HBRD.
maybe a USG had depending on the characteristic of the lesion of the liver as well. Biopsy, USG had a biopsy from the liver as well might help the diagnosis.
That is suggestive of malignant cells.
Wait,
They are not able to differentiate whether it is a squamous cells or adenocarcinoma. They are fully differentiated.
uh, if it comes up to be too confusing, then it still could be a maybe a red tube.
So what will you do then?
Then I would proceed with the cities.
So you will proceed with the CT scan. And suppose that's finishing of biopsy is suggestive of moderately differentiating adenocarcinoma. They are not able to comment further. Then what will you do?
It's going to confirm the origin of the
See, you have a provisional diagnosis of a chronic pancreatitis, right?
yes,
With superimposed malignancy.
yes, sir.
Got my point. So, is
Yes.
ultrasound is a diagnostic modality of choice to confirm the diagnosis of chronic pancreatitis?
No, sir.
What imaging you will get for the confirmation of the diagnosis of chronic pancreatitis? You don't have any previous records in your head at present, right?
Yes.
You have a diagnosis
Uh,
of tentative diagnosis of chronic pancreatitis. You have a past history of acute pancreatitis. Patient was operated twice. He underwent ERCP. So how will you just confirm the diagnosis of chronic pancreatitis? Malignancy is a complication, right?
yes, sir.
So you need to have some cross-sectional imaging in your head to confirm this diagnosis, as well as to understand its complication for their assessment.
Yes.
And when the CA19.9 is more than 5,000, then you have to assess where is the malignancy, because ultrasound is not good enough to assess the pancreas per se. They may show some
Yes, sir.
calcification, some ductal dilatation, some vague mass, but still they are not able to characterize anything. They are not sensitive enough for the pancreas assessment. They will
Yes, sir.
give you information regarding the distant metastasis, some ascites node, liver as well, like that. But for the vascular assessment, pancreatic mass assessment for chronic pancreatitis, diagnosis, complication, you have to have the CT scan. Because if you don't get the CT scan, in reality, what will happen? You get the diagnosis of malignancy or secondaries, you will send it to the medical oncologist, they will get the CT scan, chest and abdomen, or even the PET CT scan. Right. But that is not the reason. But still, you have to get the CT scan abdomen at least. So at this stage, I will
Yes, sir.
suggest that the purpose of getting ultrasound would be a totally different. It would be assessment of the biliary system. Might be some stones where there are sludges there, but that is again unlikely given the very long history and the onset at the age of 18. Because during last 20 years, he must have got many ultrasounds.
Yes.
Got it. So again, what is next?
Next,
So we have just 7 minutes more. So what is next? Ultrasound.
So,
Okay.
USG was done for suggestion for bilateral renal calculus. The pancreas was heterogeneous with a MPD diameter of 10.7 mm. When multiple MPD calculus in pancreatic membrane. And along with they found cystic mass in the body and tail region with some mild vascularization, and they were not able to characterize the cystic lesion properly.
So basically, there are bilateral renal stones, and they are features suggestive of chronic pancreatitis with a mass in the body tail area, right? And what is the size of the mass they have mentioned? It is around 6.7 to 4.4 centimeter.
Yes.
Some calcification inside. So what is next investigation? And liver
So
is
given the
normal.
history
No
of
evidence of metastasis as such. No ascites, no retroperitoneal evidence. And spleen is normal, and they have not mentioned the portal vein. Mentioned portal vein normal, right?
so at
So what
this
is the next?
stage with the history of our renal calculus, I would still like to get a baseline parathyroid.
Baseline PTS level. Okay.
Did you get a serum calcium done?
No, so the investigations are yet to be done for this patient when it comes to case.
Yeah, that would be indicated because of bilateral renal
Yes.
calculi and chronic pancreatitis.
Yes.
Hypercalcemia as an etiological factor for chronic pancreatitis is well known.
This was a MRCP image of the patient was talking to
No,
although
go back.
Yeah.
So what would you do now? Leave apart MRCP was done.
I would probably get an MRI with MRI abdomen contrast with heavy contrast.
No, what is
So,
heavy
characterize-
contrast? What is heavy contrast? Okay, again.
Uh,
Initially, you started with ultrasound, then you switched over to CT scan, then went back to ultrasound. Now going ahead with the MRCP with contrast. Why not CT
sir,
scan?
sir, given the basis, given that there is a patient that is possibility communicating with the ductal system, there are intraductal stones present here, and the patient, and we have to so and single investigation would be a MRI with MRI abdomen angiography.
Why not CT scan? What is the advantage of CT scan over MRI in chronic pancreatitis?
So because of
You have a strong suspicion of chronic pancreatitis with a malignancy, right? So what is the advantage of getting the MRI in this patient over CT scan?
in the background of chronic pancreatitis, I think MRI with ductal involvement, MRI would be a better investigation than the CT scan. The CT scan have shown to better delineate the vascular anatomy for malignancy patients.
What is the disadvantage of MR? What is the problem with the MR?
So any fluid, any small fluid connections would interfere, or any edema would interfere with the proper evaluation.
Can IPMN present like this?
Yes, sir, but the stones, intraductal stones are not very common. But it can present. And in the background of chronic pancreatitis, I would still prefer. That was the first thing.
I think a CT scan or CCT abdomen would be a better modality in this situation because the stones and small calcification, they are better assessed on the CT scan compared to MR. So CT scan is the one package that can give you all the information, whether it is a ductal dilatation, calcification, stone, their topography, their size, vascular assessment, and when you have a suspected mass lesion, its assessment also in terms of the local receptivity, distant metastasis, like that. Right. And as a surgeon, we are more comfortable with the CT scan in reading it compared to MR. So the stones and calcification part, that is better assessed on CT scan compared to MRI. MRI might be better for the ductal anatomy assessment, but in this situation, I think usually that is not the first line investigation, first line cross sectional imaging, until unless there is some contraindication to get the CT scan. And to say that mild edema or food collection will interfere with the MR, that is not correct, right? Actually, the mild food collection of edema, that is better assessed on MR compared to CT scan. Only if there is a large amount of collection or there is a gross ascites, that will interfere with your assessment on MR. In this situation, CT scan would be definitely better. So I think overall CT scan is the preferred investigation. It is the cross-sectional imaging of choice until there is some contraindication to get it. But given his condition at present, right, he is stable, there is no real failure part, right, and patient, there is no contraindication as such for getting the CT scan. It should be the first line investigation. Okay, but you got the MR, so just go ahead with the MR. We have just 1-2 minutes more.
So the uh,
Right, so read it.
sorry, sir.
See, this is of February,
Yes,
but you said no previous investigations available. Records
sir.
available.
So older records are not available of the previous surgery, but the last 3-4 months I do have the records and I have the films.
So this is something which was not done from your side, which was again
No,
which
sir.
was done at some other center. And that,
Yes, sir.
so what is the your interpretation of the MRCP images?
So the already is distended. I can appreciate the right and cutting of the smooth extravilary system with the pancreatic ductal systems are the reconstruction images but there appears to be a large enhancement, whether it's a pancreatic duct or cystic lesion, not multiple. And the continuity of the pancreatic system is also
Trial.
Okay, I think it's already 10. So maybe we can wind up. Sir, you want to ask anything else?
Sir, let us finish the CT discussion,
Okay,
sir.
sir.
Five
Sure.
minutes more.
there was a CG done elsewhere, and it just read out the impressions. It says that is it was suggestive of a chronic pancreatitis with BG mass of fibrotic etiology involving the body region with the vascular enhancement. They have described multiple vessels, the spleen junction and the vertical system involved here. With few subcentimetric FDG event report in the reported information. There was a suggestion of a phlegmonous neck, which was not significantly away in the left anterior pararenal space. There were no evidence of distant metastasis.
Okay, what will you do now?
Considering this to be a malignancy, sir, I would, and without any gastric outlet obstruction or jaundice, so I would so like to get maybe a US-guided biopsy done on lesion to confirm. Because, sir, sorry, I'm going to the discussion, but again, a different CT scan was done for which I have the films. The CT angiography upper abdomen was done. Well, this CT was suggestive of background of chronic pancreatitis. When this they suggested it was a mold of necrosis with resolving it. There was a splenic vein thrombosis as well with multiple collaterals. Suggestion of a left-sided portal hypertension. There were ectopic collaterals in the Morrison's polyphase. But in this CT scan, they have not given evidence of metabolic malignancy.
So what will you do now?
So based on this, sir, I would like to get the US evaluation done to characterize what the lesion is, if there are any significant nodules which can be biopsied from. I would like to get if possible, a fluid analysis from the cystic lesion. If I'm expecting a raised CA99, if any malignant cells, if possible, can be get from the center.
Anything else you will assess on endoscopy and endoscopic ultrasound?
So,
See, what will you ask your gastroenterologist to look for?
So I would like him to characterize the lesion, to look for the vascularity of the lesion,
Besides
to look
this
for
lesion,
any
besides this lesion, considering
beside this
the vascular complication on CT scan.
Trial.
See, there is a sphenic vein thrombosis. There is a left-sided portal
yes,
multiple collaterals. So you will look for there is a sphenomegaly as well.
Sphenomegaly, as well as if there are any gastric confinement varices.
Trial.
So you look for the signs of portal hypertension, right? And
Yes,
what about
yes.
on endoscopic ultrasound assessment? You took the biopsy, and that is suggestive of just inflammatory signs. Then
So
no evidence of malignancy.
Trial.
if there is no evidence of malignancy, still with a suspicion, I would like to do a diagnostic laparoscopy, assess if any small metastatic lesions or lesions were missed
So
on the
basically,
CT or
you
PET
will
scan.
start with the diagnostic laparoscopy to rule
Yes.
out any distant metastases, right?
Yes, sir.
And suppose they are not there, then
Then I would like to go ahead and examine. Then I would convert it to laparoscopy, reach the lesion,
hey, what
assess
would
the
be your
lesion.
final plan? That is what would be your final plan?
I would like to drain this lesion, that drain the vessels accessed. And while draining, if I get any mass or nodular thing, I would get a frozen biopsy done. Proceed with just a drainage or to go ahead with a resection.
With resection.
But again, sir, given the status of the collaterals, I would also like to keep in mind that the liver condition might not be so amenable for a major resection. That we will assess.
Sir, anything else you want to ask? Besides,
I think we'll stop here and continue the discussion in the next class. JST also is asking us to conclude.
right. Okay, thank you, everyone.
Thank you, sir, very much.
Thank you, sir.